When we look at pterygium, there are two main goals of surgery. Primarily to achieve a good cosmetic outcome, and the second goal being minimizing the chances of recurrence. Now, the traditional technique of conjunctival autograft was described way back in 1985 by Kenyon et al. And still remains the gold standard for these cases, and it achieves both these goals. Before I talk about the surgery, I would like to go over the parts of a pterygium to really understand the surgery a little bit better. We have the head of the pterygium, which is the part which lies on the cornea. Then we have the body of the pterygium, which lies over the conjunctiva, and the junction between these two is called the neck of the pterygium. The whitish or the yellowish degenerated conjunctiva that we see here is actually the elastotic degeneration. And understanding this helps us in surgery, because essentially what we are going to do is that excise the head of the pterygium and strip it off from the corneal surface, and then remove all of this degenerated conjunctiva, and then put a conjunctival autograft on the bare sclera that's created. So now I'm going to start with excision of the head of the pterygium, and I'm going to demonstrate this by two different videos here. In the first video here, I am first stripping the head of the pterygium from the corneal surface, and then subsequently excising the neck of the pterygium, and then clearing off the remnant tissue with the help of a number 15 blade. Alternatively, what we can do is we can undermine the neck of the pterygium first, and then free the head of the pterygium, and then use two sharp forces, one for counter traction and one to hold the tissue, and then strip it from the corneal surface. And in both of these cases, we have to clear off the remnant tissue which is remaining on the cornea. This works for most cases, but sometimes we do have these large adherent pterygia with significant amount of corneal scarring, where just simply stripping off the pterygium won't work. And when we are faced with a case like this, we must ask for certain histories. A history of prior pterygium surgery could be a recurrent pterygium, or a prior history of trauma or chemical injury. Here, a crescent knife comes in handy, and we can dissect the scar as well as the pterygium tissue using the crescent knife. And we have to be extremely careful, as the crescent is way sharper than a number 15 blade. We can land up with a multiplanar dissection, or we can end up going deeper than that we intend to. So now that we have talked about excision of the head of the pterygium, I am going to demonstrate a video about how to harvest the graft and how to secure it in place using fibrin glue. So here we are excising the subconjunctival tissue. Again, the appearance of the tissue gives us a clue, and we go in with using a technique of blunt dissection. We go in with our scissors closed, and we open the scissors as we go in, avoiding to buttonhole the overlying conjunctiva, and thus dissect, and then free up the tissue from the underlying sclera and cause the dissection. Then we measure the defect that's created and harvest a conjunctival autograft. Here we could use a subconjunctival lignocaine or BSS as well to determine the plane, and the aim here is to avoid Tennant's capsule in the conjunctival autograft and to harvest a graft as thin as possible. I typically like to oversize the graft by about 10 to 15%. It's easier to trim down the graft if need be. And we do not need to include the limbus for most of the cases. And after trimming down the graft, we are using fibrin glue, using the fibrinogen and thrombin, both the components, in two different 1 ml needles mounted on a 26 gauge needle with a syringe on 1 ml. And then once the graft is secured in place and ironed out well, important tip here is to remove this excess overhanging tissue from the limbus, and this greatly helps in improving the cosmetic outcome for the patient. I'm just going to quickly demonstrate the technique of using sutures for these cases. Here I'm using subconjunctival BSS to harvest the graft. This again gives us a thin graft and helps us in delineating the plane a little bit better. And then we use this interrupted atovitral sutures, taking the episteral bites. If we take the episteral bites, that provides us with better apposition as well as prevents the ballooning up of the graft. So typically we need two sutures on either side of the limbus to secure the graft well. If we have a large graft, we can even place a suture in the middle, and then securing around 3 to 4 sutures, is not more than that, is what we require on the conjunctival side as well. So let's talk about advantages of fibrin blue over sutures. This is a Cochrane review which was conducted, looked at the data including 14 RCTs, and the surgical time on an average was found to be 17 minutes lesser when fibrin blue was used. Surgical time becomes more important when we are dealing with double-headed pterygium or when we are doing a cataract plus combined pterygium surgery. The patient is more comfortable, and there is no level of evidence to suggest that there might be lesser chances of recurrence with fibrin blue. The main disadvantage of using fibrin blue over sutures remains the additional cost of the fibrin blue. There is again a low level of evidence to suggest that there might be a higher complication rate of graft dehiscence in particular. But graft dehiscence depends on a lot of factors, including graft preparation, the manipulation of the graft, the surgical expertise, and eye rubbing by the patient. These were the factors which were found in this Cochrane review. So I'm just going to end with a few tips to avoid these complications. First is to have a meticulous graft preparation, to have a thin autograft to begin with. It sits in better and there is less chances of displacement. To dry the scleral bed before the application of the fibrin glue so that we have a thin layer of glue on top, and then to use the thrombin and fibrinogen components separately, typically onto 1 ml syringes mounted on 26 gauge needles, and iron out the graft well after securing it in place. Equally important is trimming the excess glue from the surface at the end of the surgery, because often it clumps up on the ocular surface, and if we try to pull instead of trimming, we might dislodge the graft. Equally important before we remove the speculum to make sure that there is no glue stuck to the speculum, and educating our patients to avoid eye rubbing post-operatively. Thank you for your kind attention, and before I end, I would like to thank and acknowledge all my mentors who have taught me this surgery. Thank you.
Thank you, Dr. Ikeda, for a lovely talk on pterygium. Any questions? Yes, please. Could you come to the mic so that we can hear you better?
So my question is, in what cases do you prefer combined cataract?
Yeah, so this is a very important question. There are a couple of factors that we need to look at when we are talking about the question that whether we should do a combined cataract and pterygium surgery in the same sitting, or whether we should take up in two different subsequent procedures. First, of course, is what the patient is looking for in terms of visual rehabilitation or pterygium surgery. A very important factor is to look at the astigmatism. When we do biometry and do a pentacam, we need to really look at, do a corneal topography or any device that you have to really look at the effect of pterygium onto the ocular surface, onto the cornea. If there is a significant amount of astigmatism, then it is better to stage the surgeries to take care of the pterygium first, and then go ahead once the surface is stable and you have stable topographies on regular follow-ups, then to go ahead with cataract surgery later on. If the pterygium as such is not inducing a very significant amount of astigmatism, typically flattening in that meridian, then combined surgeries can be planned and we can take care of pterygium as well as cataract in the same sitting. Thank you.
Thank you.